Semaglutide, anti-diabetic agent, glucagon-like peptide 1, GLP-1 receptor agonist, used as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. Risk reduction of major cardiovascular events, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke in adults with type 2 diabetes mellitus and established cardiovascular disease, and as an adjunct to reduced calorie diet and increased physical activity for chronic weight management in adults with an initial BMI of more than 30 kg per meter square obesity or more than 27 kg per meter square overweight in the presence of at least one weight-related comorbid conditions such as hypertension, type 2 diabetes mellitus, and dyslipidemia, and for pediatric patients more than 12 years of age with an initial BMI at the more than or equal to the 95th percentile standardized for age and sex obesity. Risk reduction of major adverse cardiovascular events, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke in adults with established cardiovascular disease and either obesity or overweight. Off-label use for non-alcoholic steatohepatitis. Data from 3 phase 2 prospective multi-center controlled trials supports the use of semaglutide in combination with diet and lifestyle interventions for the treatment of non-alcoholic steatohepatitis. Benefits were seen in patients with or without type 2 diabetes mellitus. We should also notice that based on American Association of Clinical Endocrinology and the American Association of the Study of Liver Disease, AASLD, clinical practice guideline for the diagnosis and the management of non-alcoholic fatty liver disease, NAFLD, in the primary care and endocrinology clinical setting, and the AASLD practice guidelines on the clinical assessment and the management of NAFLD. Semaglutide is effective and recommended for the treatment of non-alcoholic steatohepatitis or NASH in patients with type 2 diabetes mellitus or with BMI more than 27 kg per meter square. To minimize the gastrointestinal effects, escalate dose slowly over at least 16 weeks to reach maintenance dose. The dose escalation should be as follows. Week 1 through 4, the subcutaneous once weekly should be 0.25 milligram once weekly, and weeks 5 through 8, 0.5 milligram once weekly, and weeks 9 through 12, 1 milligram once weekly, and weeks 13 through 16, 1.7 milligram once weekly, and more than or equals to week 17, see maintenance dose. If a dose is not tolerated, consider delaying further dose increases for 4 weeks. And when it comes to the maintenance dose, children more than or equals to 12 years and adolescents less than 18 years, subcutaneous semaglutide 2.4 milligram once weekly per the manufacturer. If maintenance dose of 2.4 milligram is not tolerated, decrease to 1.7 milligram once weekly. If the weekly dose of 1.7 milligram is not tolerated, discontinue semaglutide therapy. However, in the STEP teens trial, patient could continue on their maximum tolerated dose. And when it comes to the adolescents more than or equals to 18 years, subcutaneous semaglutide 2.4 milligram once weekly, and if not tolerated, may temporarily decrease dosage to a weekly dose of 1.7 milligram for up to 4 additional weeks, then increase to 2.4 milligram once weekly, and as per the manufacturer, therapy should be discontinued in patients who cannot tolerate the 2.4 milligram per week dosage. Generally, for the oral semaglutide, it should be administered on an empty stomach more than or equals to 30 minutes before the first food, beverage, or other oral medications of the day, within less than or equals to 4 ounces of plain water only. The manufacturer recommends eating 30 to 60 minutes after the dose. Considerations and concerns for adverse reactions. Acute kidney injury, or AKI, which sometimes requires dialysis, has been reported with semaglutide and other glucagon-like peptide 1 receptor agonists. According to the manufacturer, AKI secondary to semaglutide was seen mostly in patients who had experienced nausea, vomiting, diarrhea, or dehydration. In a post hoc analysis of the multiple clinical trials, there was no difference in incidence of acute kidney failure between semaglutide and comparators, including placebo. Diabetic retinopathy, an increased incidence of diabetic retinopathy complications, or DRCs, was noted during the SUSTAIN 6 study, a clinical trial evaluating the impact of subcutaneous semaglutide on cardiovascular outcomes in patients with type 2 diabetes. Complications included vitreous hemorrhage, onset of diabetes-related blindness with an intravitreal agent, or retinal photocoagulation. In a separate analysis of SUSTAIN clinical trial data, the effect was reported to be mainly observed in patients with pre-existing diabetic retinopathy, DR. and primarily attributable to the magnitude and rapidity of reduction in hemoglobin A1C during the first 16 weeks of the trial. We should also notice that this effect has been observed with subcutaneous semaglutide, exenatide, and dulaglutide, but not other glucagon-like peptide 1 receptor agonists. Trials are underway to better understand the long-term effects of semaglutide on diabetic eye disease. Oral semaglutide has not been associated with an increased incidence of DRC, gallbladder disease, and biliary tract disease, including cholelithiasis and cholecystitis, have been reported with glucagon-like peptide 1 GLP-1 receptor agonists. Gastrointestinal effects, mainly abdominal pain, constipation, diarrhea, nausea, and vomiting, are the most common adverse reactions associated with glucagon-like peptide 1 receptor agonists, including semaglutide. Hypersensitivity reactions, such as serious immediate hypersensitivity reactions, including anaphylaxis and angioedema, have been reported with glucagon-like peptide 1 GLP-1 receptor agonists. Exendin-based GLP-1 receptor agonists, such as exenatide, lexacenatide, are associated with a doubling of reporting odds of anaphylactic reaction compared with human analog GLP-1 receptor agonists such as liraglutide, dulaglutide, and semaglutide. Medullary thyroid carcinoma. In the early stages of drug development, thyroid C-cell tumors were noted to have developed during animal studies with semaglutide. It is unknown whether semaglutide causes thyroid C-cell tumors in humans, as the human relevance of semaglutide-induced rodent thyroid C-cell tumors has not been determined. According to the manufacturer, human cases of medullary thyroid carcinoma, MTC, have been reported with liraglutide, another glucagon-like peptide 1 GLP-1 receptor agonist. Cases of acute pancreatitis, including hemorrhagic pancreatitis and necrotizing pancreatitis with some fatalities, chronic pancreatitis and pancreatic adenocarcinoma, have been reported with the use of incretin-based therapies such as dipeptidyl peptidase 4, DPP4 inhibitors, glucagon-like peptide 1 GLP-1 receptor agonists. And we should also notice that acute pancreatitis was observed with semaglutide at rates similar to placebo during the SUSTAIN 6 trial. Mechanism of action: semaglutide is a selective glucagon-like peptide 1 GLP-1 receptor agonist that increases glucose-dependent insulin secretion, decreases inappropriate glucagon secretion, slows gastric emptying, also acts in the areas of the brain involved in regulation of appetite and caloric intake. 8 liters volume of distribution for oral administration, and for subcutaneous administration 12.5 liters. 99% of protein binding to albumin. When it comes to the bioavailability, 0.4% to 1% for the oral administration and 89% for the subcutaneous administration. Half-life elimination 1 week. Time to peak for the oral 1 hour, and subcutaneous administration 1 to 3 days. FDA approval date is December 5th, 2017. We should also notice that it may require a dose reduction of insulin and/or insulin secretagogues, such as sulfonylureas and meglitinides, to avoid hypoglycemia. And due to the lack of additive glycemic benefit, avoid use with dipeptidyl peptidase 4 inhibitor. And when it comes to the oral dose, administer more than or equals to 30 minutes before the first food or beverage or other medications of the day. And initially 3 mg once daily for 30 days, then increase to 7 mg once daily, and may increase to 14 mg once daily after 30 days on the 7 mg dose if needed to achieve glycemic goals. The lower initial dose, 3 mg daily, is intended to reduce gastrointestinal symptoms. It doesn't provide effective glycemic control. When it comes to the missed dose in the oral dosing, the missed dose should be skipped and resume at the next scheduled dose. And when it comes to the subcutaneous administration, the initial 0.25 mg once weekly for 4 weeks, then increase to 0.5 mg once weekly, and may increase to 1 mg once weekly after 4 weeks on the 0.5 mg per week dose, if needed to achieve glycemic goals. The dose may increase further to 2 mg once weekly after 4 weeks on the 1 mg per week dose, if needed to achieve glycemic goals. Maximum is 2 mg per week. We should also notice that the lower initial dose, 0.25 mg weekly, is intended to reduce the gastrointestinal symptoms, and it doesn't provide effective glycemic control. If changing the day of administration is necessary, allow at least 48 hours between 2 doses. And when it comes to the missed dose for the subcutaneous administration, the missed dose should be administered as soon as possible within 5 days and resume usual schedule thereafter. If more than 5 days have elapsed, skip the missed dose and resume administration at the next scheduled weekly dose. When it comes to the conversion from the oral semaglutide to subcutaneous semaglutide, if current oral is 7 mg once daily, there is no equivalent subcutaneous dose provided in the manufacturer's labeling. Some experts convert to 0.5 milligram subcutaneous once weekly and beginning the day after the last oral dose. Monitor glucose more closely during the transition. If current oral dose is 14 milligram once daily, convert to 0.5 milligrams subcutaneous once weekly and beginning the day after the last oral dose. And when it comes to the conversion from subcutaneous semaglutide to oral semaglutide, if current subcutaneous dose is 0.5 milligram once weekly, convert to 7 or 14 milligram orally once daily and beginning within 7 days of the last injection. If current subcutaneous dose is 1 milligram once weekly, there is no equivalent oral dose provided in the manufacturer's labeling. Some experts convert to 14 milligram orally once daily and beginning within 7 days of the last injection. And when it comes to the dose regimen for chronic weight management, for the subcutaneous semaglutide, we should initiate and adjust dose using the following schedule in patients who don't tolerate a dose increase and consider delaying the increase for an additional 4 weeks. Week 1 through week 4, 0.25 milligram once weekly, and week 5 through week 8, 0.5 milligram once weekly, and week 9 through week 12, 1 milligram once weekly, and week 13 through week 16, 1.7 milligram once weekly, and week 17 and thereafter maintenance dosage, 2.4 milligram once weekly, preferred regimen. If not tolerated, may use an alternative maintenance dosage of 1.7 milligram once weekly. We should also note that the manufacturer recommends discontinuing therapy in patients who cannot tolerate the 1.7 milligram per week dosage. However, some patients may achieve goal weight loss on a sub-maximal dose and may continue on the maximum tolerated dose even if less than 1.7 milligram per week. And we should also consider discontinuation if at least 5% of baseline body weight loss has not been achieved within 3 months. The missed dose should be administered as soon as possible within 5 days and resume usual schedule thereafter. If more than 5 days have elapsed, skip the missed dose and resume administration at the next scheduled weekly dose. If 2 or more consecutive doses are missed, resume dosing as scheduled. Alternatively, may reinitiate dosage adjustment schedule. US Boxed warning: in rodents, semaglutide causes dose-dependent and treatment duration-dependent thyroid C-cell tumors at clinically relevant exposures. It is unknown whether semaglutide causes thyroid C-cell tumors, including medullary thyroid carcinoma (MTC), in humans, as human relevance of semaglutide-induced rodent thyroid C-cell tumors has not been determined. Semaglutide is contraindicated in patients with a personal or family history of MTC or in patients with multiple endocrine neoplasia syndrome type 2 (MEN2). We should also notice that HCPs should counsel patients regarding the potential risk of MTC with the use of semaglutide and inform them of symptoms of thyroid tumors such as a mass in the neck, dysphagia, dyspnea, persistent hoarseness, and routine monitoring of serum calcitonin or using thyroid ultrasound is of uncertain value for early detection of MTC in patients treated with semaglutide. And when it comes to suicidal thoughts, the FDA has been evaluating reports of suicidal thoughts or actions in patients treated with glucagon-like peptide 1 receptor agonist GLP-1 RAS. A preliminary evaluation has not found evidence that the use of these medicines causes suicidal thoughts or actions, but the FDA is continuing to investigate this issue. Patients shouldn't stop taking GLP-1 RAS without consulting their healthcare provider. The HCPs should monitor for and advise patients using GLP-1 RAS to report new or worsening depression, suicidal thoughts, or any unusual changes in mood or behavior.